So good morning, ladies and gentlemen. I welcome you to this section 3B on policy interventions to improve rational use of medicines in low and medium income countries. Well, as the title suggests, you find that it promises to be an exciting one, and actually at the very core, of this meeting, because we have to look at interventions with the aim of improving rational use of medicines. I'll have with me Lilia Eugenieva Zinganshina from Russia as co-moderator, and Lily Rafed, who will be the rapporteur for the session. We're going to have a straight course, I think it's less than 2 hours now, with the presenters taking the first segment of it, each presenting for about 10 minutes, at the utmost 12 minutes. And we'll have all the presentations, and then we go on to clarification of questions, and then the discussions that will follow. We try to make our discussions as focused as possible so that we can meet the objectives, of the session. Well, I'm Ambrose Issa of the University of Benin, Nigeria. I think I will now quickly hand over to Lilia to invite the first speaker, and we'll take it alternately. Lilia, come in, please.
Thank you very much, Ambrose. Good morning, ladies and gentlemen. This is a great honor to be here at this great event. And I'm Lilia Zinganshina from Russia, Kazan Federal University, and I'm happy that I've been working with WHO on rational use of medicines since 1997, which makes it from the very first issue. And it is now my pleasure to invite Dr. Birna to give her first presentation. Dr. Birna represents, she is a chief of party for Uganda, and she represents SURE program, which is Securing Ugandan Rights to Essential Medicine. This is a USAID-funded 5-year program implemented by Management Sciences for Health. And Birna will be giving a presentation, New Performance-Based Reward Strategy to Improve Pharmacy Practices, Financial Management, and Appropriate Medicines Use in the Public Sector in Uganda. Thank you very much, and you are most welcome, Birna.
Thank you very much. And good morning, ISIOM 2011 participants. In surveys, it's often the quality and not the quantity, and I think it goes for this audience. I'm very happy to have this opportunity to present to you some of the studies we have started in Uganda to try to improve rational medicine use. Oops, it's me. We are building the strategy that we are implementing based on experiences from past issues. We in Uganda are facing similar problems to many other countries, that we continue struggle with inappropriate medicines use, which one of the causes is that we don't have the medicines available when we need it, and another problem is that we can't quantify the needs and we can't implement well practices for supply chain management. And to address that, something that had been tried to be addressed for many years, the government called for new innovative thinking. And it's based on that we developed a strategy that is based on a multifaceted combination of several strategies: education, managerial, regulatory, and finance, and based on the experiences we have gained from ISIOM, where a reward or a recognition strategy seems to be more effective. So therefore, we combined on-the-job training plus a manual with standard treatment guideline with a recognition strategy and a performance assessment. We call it SPARS, and stands for Supervision, Performance Assessment, Recognition Strategy. To do on-job training, we wanted to make supervision a new approach. All have knowledge about supervision, but we wanted to move away from a police mentality to a partnership, a teamwork. And we did that by making a 2-week training course for medicines management supervisors selected by the districts, both from district and health sub-district level, who underwent a 2 weeks training that ended with an exam. The course, of course, had a curriculum that emphasized rational drug use, but also supply chain management, and perhaps most importantly, also how to communicate and how to measure performance. The course, for those who passed, and initially we had 25% failure rate, it improved over time. They also had to go into a practice training course. The performance assessment was based on 25 qualitative and quantitative indicators, and it was the recognition strategy that was difficult to implement. We've just started it, but what is important is that it recognizes both good work from the supervisors, the MMSs, and from the facility. And it could range from giving IT skills to the medicines management supervisors. They were receiving or are receiving, because we're in the place of implementing it now, a netbook. This is very important with a netbook. Not only does it give them computer skills, but it also enables us to emphasize on data collection from the field to the central level. And we have heard already now, also in the summary this morning by Dennis, the importance of using new technology in making information available. Managers need information, we need information. The strategy or the study aimed to assess impact of SPARS, the Supervision Performance Assessment combined with a recognition strategy, implemented by trained management supervisors. We also wanted to assess what comes out when we add financial management and what comes out when we computerize hospital stores. And we wanted to monitor it on the impact on stock and storage management, prescribing and dispensing practices, and ordering and reporting. The methodology we used, we ensure the securing Ugandans' right to essential medicines cover 45 districts. They were selected not by randomization, but so that they represented the whole country, and based on a league scoring table, we selected both high performers and low performers. We are using a control group which is randomly selected from the rest of non-sure districts, covering 9 districts. All facility levels are included. The design is pre-post, and we are also doing a longitudinal study. Right now, at the time of presenting, we are only able to present preliminary results covering the first districts, the 9 districts we have had interventions in at this time, and it's 72 facilities. However, do not be disappointed. We have very encouraging results to share with you. This is a bit complicated, but what it shows is the 2 types of interventions that we are dealing with. There's an intervention A, which is all facilities in all 45 districts. We start by doing a visit. That is then where we assess performance. Then, based on the findings, we do on-the-job training, the MMSs do. 2 months later, we do another visit, assess performance. Again, do on-the-job training that is agreed upon with the staff. Then 3rd visit, and so on. To assess sustainability of the impact, we have a 6-month period where we will not do any supervision and then just performance assessment. We are here now. We have done 2 visits and done a 3rd to assess impact, and the impact only arises from 2 on-the-job training. In Uganda, we have had an approach where we have introduced kit systems for lower level facilities. We therefore cannot follow all facilities in the second part of the study. It does not make sense to train people in financial management if they do not decide on procurement themselves. So to continue in the second part where we assess finance impact and computer impact, we have taken all the higher level facilities and all hospitals in the 45 districts. They are randomly selected to each of the 3 intervention groups. 1 a control, 1 where they computerize the store, and 1 where we do financial management. And where we are now at this time, we have developed guidelines and manuals for financial training, and we are ready to start the training of the medicines management supervisors. To compare with the pre-post intervention here, we have a control group from 9 districts that are not supported by the SURE program, and we have baseline studies now. The baseline study clearly confirm the need for action. We have humongously high prescribing of medicines, polypharmacy. 5 drugs per prescription is not unusual. We treat with antibiotic to almost all patients. Injections are highly used, so there's really a need for action. These are the indicators. Some of them are very well known to you. These are the indicators that are developed and tested by WHO, but we also have a few new ones. Those you know is dispensing time, looking at packaging material, the equipment that we use, what services are available, etc. In prescribing, we look at adherence to standard treatment guidelines and all the normal indicators. In stock and storage management, do they use the practices we want? Do they store and have a clean store? Things like that are very important when you want to assess good pharmacy practices. There's a study that has some of these indicators also assessing good pharmacy practices, and we use that as background for developing those indicators. This is the results. The blue one indicates how it was when we started at the first visit. Then this is the third visit after 2 interventions. And what is interesting is that we see a change in all 5 areas. And we see that it's not just knowledge that is needed to make those changes. Some of them was behavioral change. We saw 58% improvement as overall, but there were indicators where we moved from hardly anybody doing to also 1,000% improvement. For instance, on the stock card, they had stock card, but they were not updated, so they were never accurate. We could not see the same recorded on the stock card as was counted on the shelf. Other improvement, so the biggest area of improvement with 65-75% is in stock management, dispensing and prescribing quality. Ordering and reporting improved 44% and storage management 30%. The areas that really improved strongly, I just highlighted some of them, not all indicators, but was the use of stock card and the correct balance. And that's fundamental for ensuring accountability and being able to quantify our needs. There's also packaging material, the use of dispensing envelopes and labeling improved dramatically. We also started seeing full course of antibiotic, and adherence to standard treatment guideline became much improved. So what are the lessons we can learn? We can learn that combining strategies with a reward and a performance-based approach is a very strong intervention for improving not only rational drug use, but also supply chain management. And all 25, but 2 indicators improved significantly. It was Wilcoxon test. The 2 that did not improve were 2 indicators where we measured lead time and how adherence to distribution. And those 2 indicators were not linked to the performance of the facility. It was central level who decided whether they were improved or not. So all indicators that were on the responsibility of the staff improved. We also saw that those areas that mentioned, blah. Some new technology. Yes. So those that improved was stock management and prescribing and ordering. But if you look at the picture, what you see is that in the first picture is before, the second is after. And please note that the staff is there on the second. They have changed to be very proud with their achievements. In the newspaper in Uganda, you often read that all health professionals are thieves and they are not worth their job. That is changing, and I think that perhaps is one of the most important changes, that they now are proud of what they're doing. What are the implications? Well, we need to continue the study and find out if financial management increased the effect. We also want to see how better information which we get from computerizing can improve rational prescribing, when we can do some thorough analysis of our prescription patterns and who use what. We also need to see, and have already been requested by other technical programs in the ministry like TB and AIDS, to try to use the same approach of SPARS in their programs. We see that by having MMS, who are Ministry of Health staff in the district, we have generated critical mass and put pharmaceutical on a new focus. We need to see how sustainable this intervention is, and we also need to look at the cost benefit in the longer term.
Birna, we've agreed about 12 minutes, if that's all right.
I think we've
Are you
finished.
finishing? Yes, please.
I'm there.
Yes, just do it beautifully then. Yeah. Thank you very much. Thank you very much indeed, Birna. It was a very stimulating presentation, and I think we all have to congratulate you with the achievements you've received, and let's hope that they will be sustainable in the long run in Uganda. Thank you very much. So now, dear colleagues, first of all, yes, we started a little bit later. We would like to allow 12 minutes per presentation. If our speakers will be able to keep with 10 minutes, that will be better because we started later off. And we will go with first 4 presentations, then we will go to discussion. And I would like to thank again Birna for finishing her presentation already with the task we are all working on, giving what we have learned, what are the implications, what are the policy recommendations, and what are the research gaps. So we will be all concentrating on this later on. So now, Ambrose, this is for you. Thank you.
Yeah, thank you, Lilia. I think we'll move on quickly to the next presentation by Gian Sun of the Center for Health Management and Policy, Shandong University in the People's Republic of China. He will be presenting the paper 345 titled The Irrational Use of Drugs in Rural China, Evidences from 2 Provinces.
Good morning, ladies and gentlemen. Sorry. It's my pleasure to be here to share our experience on improving drug use in China. Before I start my presentation, I want to say it's not an evaluation project. As I just show here is the basic situation of irrational drug use, especially in rural China. Now, currently, we are getting the financial and technical support from Chinese Scientific Foundation and also Swedish partners to conduct a new round study. We want to design and implement intervention to improve the rational drug use in the rural China. So here I just show some basic data on of the basic situation in rural China. For improving the use of medicines, Ministry of Health has actually issued a series of policies such as the treatment guideline and also the formulary and also the regulation on prescriptions, and also carry out some health promotion activities in the hospitals and in the communities. But up to now, we have not very clear about the effect of the policies. As you know, in China, if they want to issue the policy, the whole countries at the same time, so it's very difficult to find a control group. So this is the problem. And so this study is want to just get some basic situation of the rational use of China in rural China by studying the behavior of perceptions of healthcare providers and rural residents. So this study is just focused on the rural area of China. It's a cross-sectional study conducted in 2008. Actually, this study is part of a project funded by EU, European Union, which is focused on the evaluation of the new rural health insurance program. This is just part of the result. And this study is conducted in Shandong and Ningxia province. Shandong province is located in the east part of China, representing a developed, economic developed area. And Ningxia is located in the west part of China, is relatively poor compared to Shandong province. And in each province, the public hospitals and the rural communities was a basic study site. In each province, we randomly selected 3 counties and 9 towns and 45 villages And also, finally, we investigated about over 13,000 rural residents by household survey, face-to-face questionnaire survey in 2 provinces. And we also collected 3,000 prescriptions at the county hospital, township health center, and village clinics to analyze the providers' behavior. And also, we have interviewed 49 healthcare providers from the county hospital, township health center, and village clinics. So this is a result. This table shows the average number of drugs and drug costs in both provinces, and we can see that. We can see. And in Shandong province, at the village clinic level, they had the most number of drugs, 4.5, compared to that in county hospital, but with the lowest drug cost compared with county hospital. And in Ningxia province, the number of drugs at the 3 levels is similar, is around 2 or 3 numbers of drugs on average. But there is a big difference between the big difference in the drug cost among the different health institutions. The county hospital had the highest drug cost is significantly higher than that in village clinics. And the result shows that in both provinces had the higher antibiotic use. You can see that at the village clinic level, both in Shandong and Ningxia province, there are over nearly 70% of the prescription with antibiotics. The situation in Shandong province is more serious compared to Ningxia. And when we find this result, we come back to ask the providers, why you use so much antibiotics. The rural healthcare provider told us, especially for the workers at village clinics, they told us they get used to use the antibiotics to treat cold. You know, the cold disease is the most common disease treated at the village clinic. They have not so much equipment. They just depend on their own experience. So they get used to using the antibiotics. And also the economic incentive is also important factors to result in this situation. You know, in China, at the village clinic, over 90% of their revenue from the drug selling. As the township health center, the percentage is about 60 to 70%. So it's a very huge revenue from the drug selling. And also there is a high injection use rate both in the province, and the proportion is on average is about 50%, half and half. Prescriptions with injections. And in the survey, we also found the rural residents, they want to use the injective drugs because they want to be recovering soon. As you know, they have not a fixed salary. They have to work every day to earn money. So once they get the fever or get some disease, when they go to the village clinics, they want to be recovered soon. So they want to you want to use the injection drugs, and also they believe the effect of the injection drugs is better than the oral drugs, and also the economic incentive is also another important reason to push this situation. And from the patient aspect, we also found the rural residents had the poor knowledge on drug use, especially on the antibiotic use. We found over 50% of the population don't know the consequence of irrational use of antibiotics. In both provinces, they have no any ideas about resistance. They don't know what's the meaning of the resistance. And also, for the rural population, they had showed the poor adherence when they use the drugs, especially on the antibiotics. The figure is 54% and 60% of the rural residents cannot comply with the medical advice. They can stop to use the antibiotics, or they can change the dosage, just depend on their own feeling. If they feel better, they can stop to use it. They don't care anything. So this showed a poor adherence for. So this is the basic result what we get from the two provinces. So we can conclude that the irrational use of medicine is very severely in rural China in terms of high antibiotic use and injection use, and the economic incentives and the lack of continuous training to healthcare providers are main reasons. And for the rural residents, their poor knowledge and wrong belief and poor adherence on drug use is also worse the irrational use of medicines. So based on this conclusion, we recommend that the Chinese government should strengthen the training, on-the-job training to the village clinics, and also we should change the economic incentive mechanism to the rural healthcare providers, trying to cut off the linkage between drug selling and their revenue. But now Chinese government initiated new round health system reform, and they have carried out the policy to cut off the linkage by removing the drug markup, and increase the government subsidy. They want to improve the drug use through these two policies. But recently, our study in Anhui province, which is the first province to conduct the pilot reform in China, is the first. It's a model in this new round health system reform. But our evidence showed even the government gives more money to the rural health provider, even government issues the zero drug markup, but their prescription behavior didn't change. The antibiotic use and injection use rate are still high, based on our currently study in Anhui province. So maybe in the next step, the training and the supervision to the rural healthcare providers are more important to improve the use of medicines. And also we should pay more attention about the education on the rural residents. We should design and implement targeted health promotions to improve their knowledge and also set up the correct beliefs on rational drug use, which I think is very important. Okay, this is my presentation. Thank you for your attention. Thank you.
Thank you very much, Son, for that very illuminating paper, characterizing the use of drugs or medicines in China. I think it's interesting we're having data coming in from China now. When we look back at the introduction of the indicators, I think China, with a large population and having this data coming in, I'm sure will be a good topic for discussion. And the use of incentives, I'm sure you will throw more light on that. Thank you very much. So I think Lillian will invite the next speaker.
Ambrose. Now, dear ladies and gentlemen, it is my great pleasure to invite Yegin Zhu, correct? Yes, to give a presentation on financial impact of judicious use of medicine in primary care. Yegin is representing a public health physician, and she is currently working at National Prescribing Services in Australia. And she is in charge of program evaluation. That's it. You're welcome.
Thank you very much, Lily. Good morning, everyone. In last couple of days, in terms of rational use medicine, we heard a lot of great presentations. It's about how big the problem is. It happens in developing countries as well as in developed countries like Australia. And we also saw great presentations about big, good policy, great programs to address this issue. And we see the policy and the programs change the people's knowledge, behavior, prescribing practice. My presentation today is to evaluation of a financial impact of judicious use of medicine in primary care settings in Australia. Does it give us a financial return? Quickly, some background. Medicines is expensive. The proportion of national health budget spent on medicine are significant in both developing countries as well as developed countries. It's about 10 to 20% in developed countries. Australia currently sits in about 16% of the total health budget. For developing countries, this proportion is much significant, it's 20 to 40%. And we heard from Professor Sun Jing yesterday in China, currently the figure sits in 44.5%. This graph shows in OECD countries since 1988 to most recent years, the proportions changed significantly, increased significantly in most of countries. New Zealand is doing very best in about 10%, but most countries is above 15%. At NPS, at where I worked, National Prescribing Service in Australia, we develop programs for both professionals, health professionals, as well as consumers in general. My presentation today is focused on the programs for general practitioners in Australia. So the programs focus for general practitioners focus on, have a range of activities. Academic detailing or educational visit is one of the major approach we have. The other programs including case studies, clinical feedback, group discussions, workshops, a range of them. The evaluation objectives of this method is to assess the financial impact of NPS programs on PBS, which is a pharmaceutical benefits scheme expenditure for the targeted drug groups in financial year 2007 to 2009. The study designs used the interrupt time series analysis. And I'd just like to mention here, we saw quite a few presentations use time series analysis. Most of them is a pre-post comparison. In my presentation, this study used is to assess the correlation between the participation of general practitioners and the outcomes, so it's a slightly different approach. Firstly, have a look of the program reach. So the column of purple columns is one program, and the orange ones are the other one. So for 5 topics, we evaluation focused on for this study, we looked at the reach for the left side is academic detailing, and the right side is other activities for general practitioners to participate. I wouldn't go to details of numbers. What I like to emphasize is that these programs are large scale, and they covered about 30 to 50% of national GP workforce. Here is key graphs. I'd like to spend a little bit more time here. Oh, it doesn't work, the pointer. I'll just lead you through this graph because it's a very important one. If we look at the blue line first, which is a general practitioner's participation of NPS intervention, the program started about 2004. This is the one example I gave here is proton pump inhibitors as an example to show the time series result. The program started April 2004 and finished about two years later. So the blue dot line shows the participation of the GP numbers. And then we look at the green line here, which is without the GP participation, what's the PBS expenditure would like, what's the trend like. And if we move to the red line, which is with NPS participation intervention, what's the expenditure estimate. The black triangles as extra expenditures for PPIs in those years. So it's a long-term period, but we've looked at 2007 to 2009 financial year. The gaps between red and blue is the cost savings or the introduced cost savings between the estimate if with and without NPS intervention. This graph is also PPI, but is on the opposite direction, because one of the key messages for the PPI programs, we also encourage GPs to switch to lower dose. For the lower dose PPIs, we expected the prescribing actually increased. So the red and the green line you can see is opposite direction, and it's showed the effect we expected. So the cost saving for PPIs is the high dose PPI expenditure minus low dose, which gave us estimate for this particular program what is the cost saving. So this is just an example of the 5 programs included in this study to demonstrate how these cost savings are calculated in this time series analysis. So that's the summary report, and I just emphasize we controlled for policy change in 2006. There is a co-payment change as well as the safety net change in 2005. So any environmental change to affect the PBS expenditure or included and controlled for. The key findings for this evaluation is a significant correlation between GP participation and the decreased PBS cost. There is a significant increase in the effect of the intervention in the initial period, but for the PPI program, the impact actually decreased after a couple of years. And the mean annual PBS expenditure reduction for this per program per drug is about 16%, which is equivalent to 18 million Australian dollars, so it's equivalent to American dollars now. This is just a summary table of the savings for 5 programs included in this study, which gave us total saving estimate to about 150 to 180 million, substantial figures here. There are some important strengths, also important limitations in this study. The strengths, we use multiple time points over 10 years period of time, and the national level data across Australian populations used. And also the intervention onset and the completions are very clearly defined. But there is some limitations. It's aggregated data on GP prescribing. We don't have indications of prescribing, so we don't know whether it is all the reduction or increase are inappropriate or appropriate. And also we try our best to control all the environmental factors. There always might be unknown factors we don't include it. In conclusion, the comprehensive education programs in primary care could reduce inappropriate prescribing, which can lead to substantial financial impact as well. Programs need refresher maybe about 2 or 3 years, depends how big the message, how big the program is. That's just a remind our policy makers and program developers to make sure we're not just developing programs and assuming it will go forever, the impact. And the robust cost-saving analysis provides a strong argument for decision makers. Doesn't matter is in low income or medium income or higher income countries, the decision makers, the money is important for them, and it does help us to argue for fundings for and activities programs for rational use of medicine. Thank you very much.
Thank you very much, Yegin. Thank you very much for keeping to time. Thank you very much for this very successful presentation. Well, we all know about Australian National Prescribing Service, and I think it used to set example to the world, and it carries this function. We hope so very much. But we'll discuss later. So now, thank you very much indeed. I'm giving to Ambrose for the next speaker.
Yes, I think we'll now go on to the last paper for the session, which will be presented by Dr. Sanita Hirunrassamee, a pharmacist from Thailand in Phramangatulo Hospital, Phramangatulo. She will be speaking on effects of listing and delisting in National Essential Medicines List in utilization patterns. Thank you.
Thank you very much for your kind introduction. Sorry. Good morning, ladies and gentlemen. The topic of my presentation is effect of listing and delisting in National Essential Medicine List on utilization pattern. Okay, for the background, first of all, I would like to explain about the implementation of National Essential List. As a major policy instrument to regulate the use of medicine, Thai government has established the mechanism since 1982, and the recent changes were made in 2008. A number of medicines were differently include addition and deletion. For example, this group of medicines for some chronic disease. The research question is that this mechanism of listed and delisted of medicines in the National Essential Medicine List could really change behavior in medicine use or not. For the objective of this study, I would like to examine the effect of National Essential Medicine List, listing and delisting on the utilization pattern on drug use. The comparisons were made for 2 points. First, delisted drug with remaining or added medicine, and the next, non-essential medicines not listed in both non-essential medicine lists, addition in the same pharmacological category. Okay. Comparison were made on 3 groups of medicines to examine the utilization pattern, including statin. If you look at statin, delisted drug as atorvastatin, and listed drug in both 2004 and 2008 is simvastatin. And the next, the renin-angiotensin drug listed in both 2004 and 2008 is valproic acid. Anti-epileptic drug listed both in 2004 and 2008 is valproic acid. And indication change is gabapentin. And added 2008 is levetiracetam. For the renin-angiotensin system, listed in the both National Essential Medical List is enalapril and losartan, and delisted is valsartan. Okay. Electronic dispensing database of outpatient care from 9 government hospitals were recruited. Segmented regression analysis of interrupted time series was analyzed. Sorry. The 24-month time series data point include in the study consists of 14 months before the implementation of National Essential Medicine List edition in 2008 and 10 months after. The utilization pattern of these three groups of medicines were compared before and after the implementation of National Essential Medicine List edition 2008. Furthermore, the comparison was also made among the three major health insurance schemes. First, the fee-for-service of civil servant medical benefit scheme. The second, the capitation of social security scheme. And the third, the capitation of universal coverage. For the result, okay. The finding of time series of the number of patients prescribed each study medicine per month exhibit no apparent change in the utilization pattern for all the items before and after the switch from 2004 and 2008 of National Essential Medicines. The statistical analysis of the listed, delisted, and non-listed medicines also show no significant difference before and after the introduction of National Essential Medicine List. For the utilization pattern across health insurance scheme, regarding the further examination of the utilization pattern among beneficiary scheme of the three major health insurance schemes revealed difference in the percentage of patients in different groups being prescribed this medicine. For example, before the National Essential Medicine List, atorvastatin was prescribed 31.5% and 3.8% and 0.6% of pattern in the civil service medical benefit scheme and social security scheme and universal coverage scheme respectively. And after the new National Essential Medical List, this percentage changed only slightly to 31.1% and 3.3% and 0.6%. Similar dispense criteria among schemes were also found in the prescribing pattern of the losartan, valsartan, and gabapentin. For the conclusion, well, that brings me to the end of my presentation. The last slide is a brief summary of what I have talked about. Let me just run over the key point again. Sorry. No significant change in the utilization pattern of the list and delisting and non-listed medicine after the introduction of National Essential Medicine List in 2008. Why the different health insurance schemes seem to have effect on the utilization. Health insurance policy appear to exert greater influence on the utilization pattern than the essential medicine policy. Finally, I would like to express my appreciation to the network of 9 hospital participants in this study. Thank you very much.
Thank you very much, Sanita. Very interesting paper. Well, the essential medicines list are supposed to be very, have some water, please, sorry. Are supposed to be very important documents for the national insurance outfits. But we see a total disregard for the essential medicine list in this case. Well, we'll be discussing that, but just to get us back into perspective, I will soon be handing over to Lilia to give just a brief, say one or two words on the first two, that's the alternate presentations, the first and third one. I'll come in and say one or two words on the second and fourth presentation. But before that, please, since we are not breaking out for coffee, if you want to take coffee, you can just sneak out, get a cup of coffee, and join us so that we don't totally deprive you of your coffee. So I will ask Lilia to say one or two words before we open for clarifications and discussions.
Thank you very much, Ambrose. And I think we have to agree on time. Now it is 11:20, so we have 40 minutes plus 45 minutes. How we split them. We have the full hour now for discussion, and then we have the rest of the time for summing up and formulating our new knowledge, implications, and research gaps. Correct? Dear colleagues, now we are starting off with a discussion of paper presented by Birna, New Performance-Based Reward Strategy to Improve Pharmacy Practice, Financial Management and Appropriate Medicine Use in the Public Sector in Uganda. And just in a very few words, I would like to remind you that this proved to be a very successful intervention, as Birna showed to us. And the implications were already there. I just scrambled them a little bit. But before you go to those implications, Birna, perhaps we will open floor for the discussion. And I would like to ask, just for the beginning, such a question. How big was the staff implementing this very challenging intervention? And what are the chances for this intervention to be sustainable in a long-term perspective? Thank you very much.
I think for an intervention like this to be successful and sustainable, it requires a lot of input. And it is a very costly implementation. We do see that. And it would only be possible with that great support we have from USAID for a limited period of time. So I think the issue is really, will we be able to, after 2014, where the SURE support ends, to sustain it? We have thought a lot about how can we ensure that. And one of the things is that staff retention is difficult. So we need a certain base. It's not a single-man job. So in each district, we have selected a supervisor to be trained, and in each health sub-district. So typically in a district, 3 to 5 people are trained. They will be catering for about 30 to 50 facilities. The important thing here is that there's a substantial amount of people who can support, so you're working as a team. We believe team approach is the solution to it. So also all regional pharmacists will be trained. Moreover, we are working with Makerere University so that all basic health educations will contain the same curriculum, so that you're not continuing mopping the floor when the tap is still running, but we are closing the gap there. So I think that's one thing that is important for the sustainability. The other thing is that it's not just knowledge. We are actually seeing a change. We are seeing that people change behavior. The aspect of support to continue doing it is really linked with our collaboration, both with NDA to have the facilities inspected, visualizing that they have achieved what they should, and also having the communities involved. I think that will be critical to sustain these efforts. And because there are visual improvements, it's easier, I think, than if it is a hidden agenda, or not agenda, but results are not visible very easily. The last is the finance. We believe that, and that's what we're testing, that 2 visits per year should be sufficient. The change from before, where they also had 2 supervisory visits, is that they will be following performance assessment and a structured approach.
Thank you very much, Birna. Dear colleagues, the floor is open for discussion, please. Where are the questions? The gentleman over there, yes?
Yeah, please, let us,
Okay, my name is...
ask any clarification questions you want to ask, please do so quickly. And try to focus so that we're able to capture the essence of this session.
I have just only... My name is Ahmed. I'm from Yemen, but work in Oman for the time being. From my experience, I think interventions carried by donor organizations are very successful as far as they are in the country. But when they leave the country, then I think the program not sustainable. I give an example in Yemen, the cost sharing program or cost sharing in medicines. It was very successful, and I think Birna, through Yemen Drug Action Program, it was very, very successful. But when the program was finished, I think it was collapsed. So this is my comment.
Well, I can only agree. It is difficult to sustain. It's easier if you have a donor to continue support. But I think if I look at the experiences from Zimbabwe, where the team approach was critical, we really were able, after donor support stopped, Sanita pulled out, the Zimbabweans were able to continue the program, and we still have people in Isium today who are from that time, and they managed to pull it through for several years until again donor EU came in and supported. So I think it's the critical mass, and the MMSs are the Ministry of Health people. It is the district people, and I think that makes the difference. It's not a consultant from EuroHealth Group or whatever, but it's really somebody who is on the ground and there every day. And it's a matter, I think what is making a difference from before is that the motivation is back. When did you last praise your staff for doing a good job? When were you last praised for having done a good job? I think it's a change to the more soft values that we need to prioritize so that our staff, when they go to work every day, are proud of what they do and that they are told they do a good job. I think that's the change we need.
Yes, please. Richard has a question.
I think the previous point's a very important one, but I do think the Australian presentation of the NPS is a signal of the way the process can work. We heard the suggestion that there should be a 5% levy on medicines, 5% of medicine sales should be allocated to rational use. If this project does improve performance substantially, it should be possible to demonstrate substantial savings. And I think we need to look forward to using the Australian approach of saying that this investment in promoting rational use and better supply chain management creates net savings. And my question, which I'm jumping forward to Qiang, is you presented the change, your time series provided a change in expenditures. Is that a change net the cost of the intervention or not counting the cost of the intervention? And I think when Birna comes to evaluate the project, I hope we'll be getting a net savings that has resulted, because I'm a firm believer that we can and should be able to demonstrate savings as a result of these effective interventions, but we need to have the power, like the Australians have done, to demonstrate those savings. So I'd be interested when you have the opportunity to also comment on the net savings side of things. Thank you.
Thank you, Richard. Yes, please, Yegin.
Thank you very much, Richard, for your compliment and the question. The quick answer is not net saving for this this program. However, we do receive funds from federal government, and the total savings of all programs exceed the fund we receive.
Yes, there is one more question. Brian, please. And I'm a bit confused now. We've turned to another presentation. The original idea was that we are discussing presentation by presentation.
I would also like to answer to Richard.
To Richard. Yes, yes. So first, Birna will be answering Richard's question, and then we carry on, Brian, if that's all right? That's fine, okay. Yeah, yes, please, Birna.
I so much agree that if we cannot document a saving financially, it is very difficult to continue arguing. It's difficult even if we have a saving of medicines and people are treated better, that's so difficult to monitor. But financial benefits are much easier to monitor. In the group we had yesterday, we need to look at the cost benefit, and we need to have new models developed so it's easier within our field to monitor the cost benefit. And that's financial saving, but it's also a little broader term. We need to see it. I think that the important thing we have from previous, the policy work WHO have done, we saw that one big change between success and failure was leadership. That means when we do interventions, we need to get leadership involved. We've tried top-down approaches for years. It's not working. They rather buy a military plane. We need to start, I think, from the community, getting them involved so they are the one who dictates the policy. And that, I think, is critical for our, hopefully, continued success with this implementation. We need to have the communities involved, and we need to be able to justify what was really achieved in a broad financial term.
Thank you very much, Birna.
Yeah, I think, I'll get to you, Brian. I think we better try to harmonize our discussions, focus on the objectives. We have already heard 4 papers, which Birna has introduced. The first one, we've asked questions about Birna's paper. We have the one on irrational use from China, and then the Australian paper, and also the one from Thailand. So I think let's harmonize it since things cross across, the various papers so that we can have a focused, discussion towards the objective. I think I'll recognize Brian now, please.
Thanks very much, Brian Godman, Karolinska, and the Land. Thank you for 4 very good presentations. I just got 2 issues of clarification, then something that goes across those. Firstly, if I come to Australia, my belief is that generic omeprazole was launched during the time of your study. And we know in the UK and Sweden, where we've done multiple interventions, that over a 10-year period, 2000-2010, our PPI utilization has gone up 3-fold, but our actual costs have gone down 60%. And that's because of generic omeprazole. So I wonder how much in your evaluation is actually launch of generic omeprazole, as opposed to moving from high-dose omeprazole to low-dose omeprazole. So I challenge you to do that. So if you could clarify that. And Birna, for your one on Uganda, when you talked about interventions to the physicians or whatever, what were they to get them to adhere to the guidelines for diarrhea, coughs and colds and things like that? Because we have great difficulty in a number of countries actually stopping antibiotic prescribing for colds. And what you've done is actually showed how way forward we can do. So I'll leave it for those 2 there and then come back to the others.
Do you want to make any comment on that?
Yeah. Thank you very much for your challenging question. And actually, the analysis I didn't have time to show. For the lower dose PPIs, that was a significant factor. It was controlled. And for the higher loss wasn't significant, and we controlled examined for both. Thank you very much.
You wanted?
Yeah, that's a very good question. and I'm not sure I have the best answer to it. We didn't have a specific approach to the prescriber, but at lower level facilities, often the dispenser and the prescriber is the same person. And what we did was we made awareness about the appropriate treatment and documented the overuse of antibiotics. And I think that in itself made a restriction in the prescription, something they were not aware of. In Uganda, the standard treatment guideline is available at high level, but it, in many cases, don't even reach the facility level. So it was, I think, this first win was really made because there was lack of awareness of what was appropriate and what was standard treatment. If we are to improve it more and go into really addressing rational drug use, I think what we have is an army of medicines management supervisors, and by doing computerization of facilities, we get a tool to get information about poor practices where we can really analyze and focus on very specific targeted interventions. But that's the next chapter. Thank you.
Yes.
Yes, there is an addition from Yegin. Please, Yegin.
Can I just make one extra point, just to make it a little bit clear, because when I was considering of the time, so the result wasn't showed in the full picture. The factors being controlled is a seasonal change, and all the policy change, as I mentioned, the co-payment change, safety net change, and as well as a new drug come to the listing, PBS listing, as well as the price change. So these are the typical factors we controlled for. Thank you.
Okay, well, if we look, following all the presentations, there are certain observations. Oh, you want this? Okay. Carry on, all right. No, you carry on. I'll come in when you are through. You, and then him at the back, and then you have another one at the middle here. Yeah.
Hello, I'm Libby Ruffhead, and I've been trying to take notes, which is a bit of a challenge. And I was just going to summarise where I thought we were up to, but I'm not sure if you'd like to go first.
To summarise?
Yeah?
No, I think, you want to summarise the, hang on a bit so that we get on a bit before you summarise.
I wanted to just summarise some of the things that I thought had come out, and hopefully you can tell me I'm wrong, and then you can help us take more notes, and we'll get to where we want to go. But I think what we heard from a couple of speakers was the importance of collecting good data. We heard the importance of collecting good and robust data from China before you even start, and how it was really important for decision makers. That same story came through from Yegin with the, but it was at the other end. And then we heard Birna say again that you actually have to keep collecting good data all the way along through. So I think there's a strong theme that has come through about the need and importance of collecting good data for decision makers using robust methods. One of the things that I thought came through, perhaps not explicitly said, but bring the training to the worker. Perhaps not take the worker to the training, but bring the... And so what we've seen is the success of initiative where we're bringing the trainer to the worker. A couple of presentations were talking again about the importance of sustainability and the need for repetition and reinforcement of messages to ensure sustainability. I think there's an underlying question of we're still not sure what are the appropriate time periods for sustainability, and that may be affected by the complexity of the intervention. It may need to be more frequent with more simple interventions, and perhaps longer with very complex interventions. I'm not sure that's clear. I'd seek some clarification. One of the other things that's come through is the importance of doing cost-benefit analysis and to start analysing cost-benefit. Just because I use a different technique, I'd be kind of talking about perhaps cost consequence or something else, because that's a little easier and that's the one I use. But I think I just want to kind of there are many ways to do costs, benefits, consequences, and I don't want the language to slip to one. One of the other things that came out was the importance of exploring variety or variation, so the importance of the regional difference versus the city difference or the rural difference, and that's a challenge in every country I know of. It's certainly our big challenge in Australia. I think they were my big ones. And of course the ongoing challenge of how do you evaluate national programs, because you don't have control groups, but that one was the main one. Richard, have you got anything else? Yeah, but that's where I am. If people can add things, if the speakers can add things that I've missed and might be about lessons learned, research questions that still need answering, that'd be great.
Yeah, you may also, I think the other bit that comes again, Lily, the other bit which I think you should also add is the multi-pronged interventional approach, which I think cuts across the two presentations. I think that should be reflected as well. And the issue of incentives is another one. The issue of incentives is another one which I think we should note. But we should wait so that we see what people's perception and what they think about it before we crystallize that. So I think we had someone there.
Thank you very much again. I have a question to Mr. Sun. As far as I know, or everybody know that traditional remedy, particularly herbal medicines in China, are very common. So when you calculated the average number of medicines per encounter, do you consider, the herbal medicines, or just only the modern or Western medicines? Because one time I visited China and I found patients are treated with traditional remedy, herbal medicines or coping like that, and at the same time modern medicines. Do you understand my question? Thank you.
Okay, thanks for your question, and I think it's the same as the question I got online. Is from Egypt. They asked me, do you have any data on the rational use of herb remedy? So I think it's the same as what, but it's a good question, but unfortunately, my answer is no, I don't have any data, because it's really, the reason is it's most difficult to get the evaluation standards. So the traditional herb is very complicated. They mix the different herbs together and can be used to treat some diseases. So it's very complicated, and not like the Western medicines. There is theory can be justified in the lab, but for the Chinese herb, it's really difficult. But I think at that time is very good time for China to pay attention on the herb use, because now Chinese government is issued a new 5 years round plan to develop the traditional medicine, Chinese traditional medicine further. So I think it's a good time to conduct it or design or conduct some kind of studies on how to evaluate the herbs use. So thank you.
My name is Paul Ashigbe. I'm from Ghana and also from Boston University. I have a question for Queen Sang. I would like to find out if you observe any gender differences in the rational use of medicines in your study.
Yes, thank you for your questions. Yeah, actually, we collected the data on the gender, but unfortunately, I have not time to show the result. The result is there's not a significant difference between the male and females on the drug use in the rural area. From the result is from household survey. There's no significant difference. Thank you.
There.
Okay, Brian Gobanin, thanks very much. My question's now to some of the others, if I can. Firstly, just to clarify on financial incentives, we've published quite a lot now, and one of the ways is in Stockholm, and we've shown that if we give physicians financial incentives for adhering to an essential drug list, then our savings are 5 times the cost of implementation. So you can achieve good savings to help with the sustainability. One of the other things that helps with the sustainability is we already talked about multiple interventions, so we don't only do education around an essential drug list, but we give the doctors prescribing targets, both for efficiency and quality. So one of the quality targets could be percentage of high versus low dose omeprazole. We also then monitor them, give them economic incentives. So not just one intervention, it's multiple, and I think that's very important to go forward and help with the sustainability. And with the systems you've got, obviously, in Uganda, that allows you to do that, allows you to monitor. So in Stockholm, our GPs get a monthly printout of their adherence to the WISE list and things like that, how they're doing against the indicators. So that's a continual drip feed. So I've put that forward as a way to enhance sustainability. Lastly, to the lady from Thailand, I was not confused by your data. The reason I say that is across Europe, if we delist a product or we make it very expensive, I'm thinking of atorvastatin in Germany, went from the reimbursement and off the reimbursement list. The patients suddenly had to pay the difference between generic simvastatin and atorvastatin, which was huge. So atorvastatin utilization went from 60% of all statins down to just 2%. Because of that extra co-payment. My colleague here in Austria, they introduced prescribing restrictions again for atorvastatin, making it second line. So in order for the patients to get their atorvastatin reimbursed, they had to have the permission of the chief medical officer of the health insurance company that they were failing on simvastatin. And again, that dropped atorvastatin utilization about 30% down to 10%. So I think is when you're looking at that analysis is what's the health policy, what's the co-payment and the other issues before you can present that type of analysis. Because what we've seen is you can get some very different results from what you've presented just because of issues such as co-payment and things like that. So perhaps you can explain what happened in your study that you didn't actually see those changes that we've seen across Europe.
Yeah, I think you want to go first? Okay. Now, I think it will be important to also clarify the relationship between the insurance companies and, maybe your government that sets up the essential medicines policy. Can you clarify that?
Okay. I think Dr. Savakon.
Oh, you need an interpreter. You need an interpreter. Can you please interpret? Come, sit by her and interpret. Did you get his question, or do you want him to repeat it?
That's okay. I am a co-author, and thank you very much, Brian, for your point. And I think this is very important, and that shows a key difference between the system that you mentioned and the system in Thailand. The essential drug list has been used long time ago, since 1982, and to guide procurement for government hospitals and health facilities. Later on, it was used by the cabinet resolution to guide reimbursement. But the word reimbursement in Thailand, we have 3 health insurance systems, as the chair already mentioned, that I need to give a little bit background on the different health insurance schemes in Thailand. We have 3 main public health insurance schemes, and Jono already mentioned in the morning. The Civil Service Medical Benefit Scheme pays on a per item basis, fee for service, for medicine, okay? And the other 2, the Social Security Scheme, which covers private sector employees, pays on a capitation basis. The 3rd scheme we call universal health insurance, but actually it's not universal. It's whatever people left off from the first 2 schemes. And this is paid on a per person basis, not capitation in the traditional sense, because not every hospital is allocated the same per person rate. So capitation as a term is a misnomer when we use it for the 30 baht scheme. Okay, now the civil service medical benefit scheme, because it's pay per item, you will see from the graph that the people who are covered, who are beneficiaries of this scheme, get more expensive medicine. Okay, high percentage of the people, of the beneficiaries in the per item payment scheme get larger percentage of more expensive medicine, while the other two get larger percentage of cheaper medicines. And these lead to the differences between the use of the different schemes rather than the total essential medicine use. Okay, so we see the flat line, and for all these three schemes, there is no co-payment for medicine. Okay, so there is no change in the out-of-pocket amount when there is listing or delisting. So that's basically, have I answered your question? All right.
Yeah, that's interesting. Yeah, Richard, please. Can you take it?
I think this is a critically important issue, and it particularly applies, I think, to China, to the China health reform that is underway at the moment. And the first point to make is that the reimbursement, the civil service reimbursement scheme, I don't know what it is now, but a few years ago when somebody came and worked with me in Geneva, there was over 3,000 items that were being reimbursed, and that the list of reimbursement was substantially longer than the Australian PBS, and the rates of reimbursement in many cases were higher than the PBS, that the civil service was paying a lot. So there were major incentives for making these medicines available, or making these medicines to be used. And I think the health insurance program in the civil service is really going to head into terrible problems as more expensive medicines come into play and have to be addressed. Now in China, the health reform is underway, and we've heard about the problems of the perverse incentives, that so much of the income for the revenue comes from the health facilities, and the zero markup has been introduced, but the sales are still going on. And what we know is that in some circumstances, there are other payments also occurring that affect it. Now, in China, the essential medicines list of 300 items, 200 or so Western and 100 or so traditional, are being supplemented by provincial lists. And those provincial lists may be anything from 50 to 300 additional items in different provinces. And it only applies to primary care. It doesn't apply to hospitals. And I wonder what your thoughts are as you are in the middle of the health reform, as you've seen all this data on the prescribing practices. How do you think the health insurance schemes in China are going to survive with such long lists of reimbursement and the perverse incentives around the payment systems, particularly bearing in mind the experiences of Thailand, that if you have enough medicines on the list, people are going to use them, and the costs to the system are going to increase dramatically. I know it's work in progress, but I do think thinking through, and as Jono said, the issue of the medicines component in any health insurance are absolutely critical. And I think every country that is looking at health insurance for medicines has to address these. Thank you.
Thank you very much, Richard. Are you going to comment to Richard's thing?
Thanks. I think it's very good question. So we should consider that
during the new round health system reform. You know, when we carry out the essential medicine, even we remove the drug markup, but the hospitals still sell the drugs to the patient, so they can sell more drugs to the patient if there is no regulation. So this is also a problem. So now the Chinese government also noticed this problem. They want to use the health insurance system to regulate their behavior. They want to change the payment method from the fee-for-service to others, capitation or hospital or per global budget, such kind of things. In most situations, in some cities, it's automatically initiated, not at the central level, just at the provincial level. Some cities has initiated a reform on payment from the fee-for-service to the capitation, especially on the outpatient service. They want to use this payment method to control the medical cost. So I think this is a very good question. Thank you. Sorry? Long lists. Yeah. Yeah, not so much, just as you said. As you know, we have 5 and 7 essential medicine lists at the central level. At the provincial level, is on average, I think it's about 60%. At least in Shandong province and Anhui province, they have not more than 500. No more than 500.
Dear colleagues, we have to greet our colleagues in Alexandria University who are watching us online, and we have 2 questions from Alexandria University. One question is to Dr. Birna. I think, Birna, you answered already, but let me give the question, and if you would like to comment on that, you will do, please. In your experience, to what extent will the achievement be sustained after the research project ends? So you...
I think I have, and we have discussed it. It was also alerted to from Yemen, and I think it is difficult to answer, but I think we are trying to address both staff retention, we are trying to address the financial aspect of it, and we are trying to also root it into political and leadership commitment. And I think all of those, it's not just one initiative that needs to take place to make it sustainable. It's all of them. And then to add to that, I do think it's important that we reach a critical mass, that we do include into our curriculum for all health workers this basic training, else we can continue training people and it will never end. And I think the financial aspect, it must someday be able to rest in itself, these interventions. And I think it's a matter also of recognizing that you cannot provide health care with 70 cents per patient. It's just not doable. And we can't invent money. We can be more effective and more rational in what we do, and we do waste tremendous amount of money. And information, evidence on what we do is the answer, I think, to a long way to guiding decision. When we know what it costs to do irrational prescribing, when we know what it costs not to do these and these actions, it's easier to convince everybody who have a say that this is the way to go.
Thank you very much, Birna. And the second question, perhaps Ambrose, would you like to take it?
Yeah, you can take it.
The second question from Alexandria University is to Dr. Sohn. So do you have data on the rational use of herbal remedies? This is just to add to Richard's question on long lists. So please, Qiang. Thank you.
Yeah, and I think I have answered this question. Is unfortunately, up to now, I have no data on the herb remediated because it's really difficult to evaluate whether it's rational use or irrational use because we lack of effective indicators. But I think it's time for us to design such kind of studies on that under the new round health system reform. So,
let me ask, I think quickly I would like Birna to maybe look or clarify the use of incentives in her scheme, or that is in her own scheme.
Yeah. Thank you very much. I think it's an excellent question, and it's again one of those that are not so easy to answer. I think from Gavi we saw that a reward-based strategy with $20 per more immunized child made the intervention effective but not cost-effective. So when you do intervention schemes where you recognize good performance, it has to be so that you don't jeopardize the cost-effectiveness of a scheme. I think that recognition should go from a daily, you're doing a damn good job, to more things which you find useful. When you live in Uganda and are perhaps a clinical officer out in a rural place, if you have a chance to come to use a netbook that might one day be your own, and you get access to internet, that's remuneration or recognition that is tangible, that is of importance. And it served two purposes. It recognized to the person that he will be better positioned in the future, but it also gives information on performance to central level, something we haven't had before. So I think it always has to be a kind of a win-win situation. For instance, for the facilities who also need a recognition, there we have aimed at having them accredited by the National Drug Authority. This will give them, like a program we had in Uganda earlier, Yellow Star, a visible recognition to the community that your facility performed to a certain level, and there is no difference anymore between lower quality and public sector. They are inspected by the same, on the same criteria who inspects private sector. So again, it's a win-win situation. And I think when you develop the recognition scheme, which is not yet developed, we are developing as we go along, it has to be feasible also in a cost-effective sense.
Thank you very much. Well, I think Lisbeth was able to get most of the observations and lessons learned from this section. So I think we should now try to get inputs now regarding the recommendations for policy and program action now, so that we want input from you. We've listened to all the papers and recommendations regarding interventions to promote rational use of medicines. Yes, please. Can we start off there?
Thank you very much again. If I just have one clarification, then a recommendation. Somebody talked about financial incentives. The reason I mention that is people who know the United Kingdom, that we offered our physicians about $50,000 a year for achieving certain quality standards. And what we're finding now is obviously their direction is towards achieving those quality standards and not doing any activity that interferes with achieving that. Versus where I work in Stockholm, we're much lower, about 1/10 or 1/20 of that. So I think if you're looking at financial interventions, you've got to be very careful, because once you put them into place, you can't take them away. And also I take Birna's point, it's not just the financial, it's everything else that goes with it, the recognition, the reporting, looking good with your colleagues, etc. So you don't have to do that much on financial incentives. And I think the UK is a very good example of just getting it wrong and just wasting all that money. So that brings me on to recommendations, and there's been quite a lot of work now in the UK, is to publish. Because I think, and I know I've been working in this area for 4 years now, and there's a dearth of publications looking at policies and their outputs. Sometimes it's very difficult because health authorities in Europe don't just do one intervention. You get a new government comes in, what happened before wasn't very good, and they just chuck everything. They might do 5, 6, 7, 8 interventions. You might have interventions at a national level, regional level, local level. So your time series analysis is very difficult. But that doesn't stop you saying, okay, what happened before? What are the interventions descriptive-wise? And what's the end result? And it's, okay, it's normally a retrospective analysis, but that's the best we've got. And at least if we publish that, then others can learn from it. And I think there's a dearth of publications. So please, all of you on the panel as well, can we publish as much as we can, just so people can share that And please also, I know it's difficult, but the English language is easier because it's easier to search those terms. So my recommendation is please to publish as much as possible. Don't worry if you don't have really sophisticated analysis. Don't worry if the reviewers come back to you and say, why haven't you done a time series? You can say, well, there are 20 interventions. Which one do you want me to choose? And I'll choose the other 19. But don't worry about that. Please, please, please publish.
Well, thank you. So you are advocating publication. Who will be publishing and who is it directed to? I think, can you clarify that a bit?
Okay, I think I work mainly with health authorities, health insurance, and I think what we've heard, and I think the example in Uganda is very good, is where you have the local health insurance people really looking and helping them evaluate, then you can get that powerful on your side, and also together with the physician associations. So I think if you publish with both of those, aim particularly more at the health authority, health insurance people, that's when I think you get the good buy-in to say, okay, this is what we've done, this is what we need to do, and get their buy-in to work towards that. And then the funding can come, and we've already talked about savings and things like that. So if they see the opportunity to improve both the quality and the efficiency of healthcare, and you're shown how to do it, then you get that buy-in to move forward. So I would aim publications at the health authority, health insurance, and that can be either at the national level, or we know, like in India and Brazil, the budget's at the regional level, so it's aimed at those. So really aim it at who holds the budget, who can influence, and go on from there.
Okay. Yes, any more contributions on this? What do we think about the essential medicine list? I think that's, he's thrown some light into what might be usefulness or non-usefulness of the essential medicine list in country settings, and also its application by the insurance or such bodies. Should that not be a recommendation to ensure that bodies like the insurance and other health-related bodies, Yes, you want to say something on that, Richard?
I think this is a very important recommendation.
Yeah.
Clearly, it's absolutely clear that the reimbursement or the payment of medicines should relate to their needs, to the efficacy, safety, quality, but the essential nature of it. The difficulty we often face is that the reimbursement list and the National Essential Medicines List may well be created and modified and adapted by different groups at different times. And I think one of the policy recommendations that I would suggest is that we should be looking to have the health insurers participating in the discussion around the composition of the Essential Medicines List. I think if we take the example from China, the China model has been using an expert group to select the medicines, and the implications of cost of their decisions was not made known to them. They were making decisions without knowing what was the cost implications of what they were doing. And I think Thailand has a very sophisticated system for modifying their essential medicines list, and we've published in the Essential Medicines Monitor about it. But I think the big problem is the people that matter, particularly the civil service health insurance program, are not part of that scheme, not part of that selection, and don't feel in any way obliged to relate to the essential medicines list. And I think that, Saul Walker talked about small p and big P politics. I think the politics in Thailand around the civil service medical benefit, what has been explained to me is that salaries for civil servants in Thailand are very low, but benefits are very big. And I would be interested if Saukan could comment a little bit on that, the politics of it, because the civil service medical scheme will go broke if there are no changes, I think. But your comment would be welcome. And I think in terms of the policy recommendation, I would be suggesting that health insurers and reimbursement authorities should participate in the selection of the essential medicines, and that the criteria should be evidence-based rather than experience-based, as it has been in many circumstances.
Yeah, definitely. I think if you buy them in during the selection stage, they should implement it as, Lydia, you want to say something on this?
I think our colleagues from Thailand were going to comment. Yes? Are you going? Yeah? Yes, please.
Yeah,
and then I will do my bit.
Thank you very much, Richard. Richard knows a lot about Thailand. And if there is any recommendation, I would go back to what Richard said in yesterday's afternoon session about practice guideline. Practice guideline as a document alone won't really work. There need to be an additional system, like for example, as Richard suggested, audit. Okay, so that same idea applies to whatever list that we put on paper. We don't just put up a list without any mechanism to make the implementation effective. In the case of the essential drug list in Thailand, we have a list, and the list is said to be said by the developer, the formulator, that apply to all different health insurance schemes for reimbursement. But the idea is that the civil service medical benefit schemes pays on a per item basis, okay, and pay retrospectively. So the medicine is dispensed, and the providers, the hospitals would submit for reimbursement from the insurer, from the, in this case, the Ministry of Finance, okay? However, the other two schemes which pays on a per person basis will be, are the prospective payment. So the hospital get the amount per person per year. And the incentives are quite different. So if you, in a system with multiple payment mechanisms, and one would think of one single list called National Essential Drug List to be applied to all the different health insurance schemes, it might be kind of too ideal to do. So there might need to be mechanisms. Like if we want to have this list, what are the mechanisms that we need to attach to the list, to the use of the list for per item payment scheme? And what are the mechanisms to be attached to the list for the per person payment scheme? Because if for health insurance, for incentives, these are two opposite sides of the coins. One, when the payment is made per item, there is an incentive for the providers to prescribe more. If the payment is made on a per person basis per year, then there is an incentive to prescribe less. So the mechanisms attached to the list in the different system need to be designed differently. That's the way I see the use of essential drug list for reimbursement.
Okay. Right. Yeah. Thank you very much. I kept writing down some keywords going to recommendations, but your answer somehow triggered one more question in me to your national essential medicine policy. WHO essential medicine concept was designed for countries to be used as a model instrument, a model product, and a model process. So I was wondering whether you are managing to use it as a model process in your country. Yes, I'm asking this. And whether this is a failure of using the model process leads to, well, these all difficulties with different insurance schemes and all these difficulties. So could you please say a little bit on that? How do you make your essential medicines list, and whether the process has been really implemented or not?
Thank you. We use since 1982, we use the World Health Organization essential drug list. At that time, we call drug essential drug list as a model. But the list itself, since the very beginning, has been different from the model. We use it as a model, but there is a committee that formulate that decide which items will be listed. And this has evolved over time from the procurement list for government health facilities to what is intended to be reimbursement list. So the list basically has expanded. And we have, as Richard already mentioned, that we have a system that a subcommittee under the National Drug Committee that look into which items need to be listed and which item delisted. In the earlier phase, the updates were slow, like many years before you have another edition of the National Drug List. Since this past 4 or 5 years, the updates are more frequent. But anyway, we need more than a year in order to get the list updated. So yes, we use the World Health Organization list as a model list, but there is a kind of quite well-established mechanisms in the development. Do we include the patients, the consumers, or the beneficiaries in the development of the list? No. We do apply some kind of cost effectiveness analysis, pharmacoeconomics, but then we don't come up to reach a point that we can decide value for money. We can decide willingness to pay, but we only compare whether item medicine 1, 2, 3, 4, for example, which one is more cost effective. Okay. Thank you.
Right. Thank you very much indeed. Just to make it very short, and if you could please answer yes or not, whether you were successful in bringing conflict of interest concept into the selection process or not. That was my feeling, that perhaps you didn't manage to bring the conflict of interest, concept into implementing your essential medicines concept for the committee members, for all those people. Do they declare their conflicts of interest? Yeah.
People in the committee, yes, they do declare conflict of interest. Yes.
Yeah, fantastic. Thank you very much indeed. Dear colleagues, we are running really, not yet running out of time, but the time is flying. So what we were doing here with Ambroise, we were trying to put some keywords which perhaps are coming together with the policy recommendations. And I would like to sum up a little bit, and then we will move to the research questions, all right? So, and please correct me if I've missed something, and add, please, and comment. So we somehow agreed on that to successful interventions, community uptake is very much needed, and the keywords never end, the community uptake and never end intervention. This is something that we're taking with us today. The generic policies need to be institutionalized and used for cost savings, then raise awareness of irrational use of drugs, and that's very much relevant to Chinese experience and the data that we used there. Then we are very much in favor of using computer technologies or IT. And the Australian presentation showed us how magnificently well the data could be used. And again, this emphasizes the recommendation, collect data as accurate as possible, as Libby has emphasized to all of us. Then we concentrated on multifaceted interventions. Then we were looking into insurance schemes and the connections of essential medicines lists and insurance schemes, and we discussed it in every detail using all the experience and expertise from our Thai colleagues. Then, this is again coming to the community uptake and raising awareness, this is our recommendation to create a critical mass and never-end intervention. Yes, then again, what we're thinking about today, use information and evidence to create your intervention, to select medicines for essential medicines list, to educate on rational use of medicines. Then we had from Brian, publish as much as possible and share knowledge. We had a concern, and we thought a lot on that about financial incentives, that whenever you use financial incentives, you can never end with that, and you have to be really very careful with financial incentives before you really try to rely on it. Just from myself, going through this, and about the trainer, bringing the trainer to the worker, I would like to ask all the members of our panel and about the audit, who would be the trainer, who would be the best perhaps trainer, and I can explain myself. I'm a little bit biased in terms of clinical pharmacology and how the training needs to be done. We haven't remembered today the Guide to Good Prescribing, which I think will contribute a lot to rational use of medicines. So this is something to end up this list of keywords, asking you to add to this list of keywords as recommendations. And so who and how will be training in all the interventions. And if anybody would like to say a few words, please. Just one word, please, yes. From our panel and from the audience, please. Yes, please.
I think training should be made sure that it is practical and hands-on training, so that it doesn't become an academic exercise. However, I do think it's important also to involve academia, but we have done it as a collaboration between people with practical experience, MMSs actually, together with the university.
Thank you very much, Birna. Anything else from our hardworking panel? No? Anything from the audience? Yes, please, Brian.
Just two very quick things. One for recommendation. I entirely endorse what Richard's saying about the insurance companies getting involved in the essential drug list. That's what we do in Stockholm County, because the person who implemented it was both Professor of Clinical Pharmacology and Head of Drug Management. And now we have about 80–85% adherence over the 5–10 years. So I entirely endorse what Rich is saying. Don't develop two lists. Just do it as one list and do it on the basis of all the WHO criteria, and that works quite well. Secondly, if you're developing an essential drug list and you've got regional or local decision makers and you've got a national one, you need to filter that down. And we've got the Brazilian experience which shows the difficulties in doing that. So I think if you look at an essential drug list, you need to be able to, and the recommendation is aim it at where the people are going to utilize it. And I think the example in Uganda is very good like that. You got it down at the local decision maker. They didn't know what the guidelines were, but until then you started to implement and work with them locally, and then they did, so get it down to there. So I think those are the two going forward. And as far as the trainers are concerned, I think it's a mixture of clinical pharmacology plus a number of European countries, the pharmacists employed by the health authority actually go out and do the detailing. So you've got those dual inputs. You've got pharmacy input, but with a health authority background. So I think that training works very well to enhance the rational use of medicine. So if we can have that as a model going forward, I think that works well.
Thank you very much, Brian. Thank you. Any? Yes, please.
Thank you. Libby Levison, just following on the last speaker and what Richard said and something that Sal said, just to make this explicit, but getting essential product lists all the way down to the facility level. But following on what Sal said, doing it periodically. There was a brilliant, the early morning session this morning about legislation and health and human rights. Make it part of the Constitution that the essential medicines list has to be revised at periodic intervals and enforce that. I mean, looking at the data from Sanita's talk, it looks like Thailand is revising your essential medicines list. Was it every 4 years? Not many countries can claim that. So I think with all of these new technologies coming, we have to keep that in mind. Thank you.
Thank you very much. And Birna, please.
Just a quick one on this one. I think it's important when we say revision of the essential medicines list that we also connect it with the standard treatment guideline. It's not two separate things, they should be very closely linked. Then the other quick I wanted to say is related to, we talked about finances and the importance of knowing what the medicines cost and the cost effectiveness. I think we need to move also, if we look at Uganda and go to a facility, because we have no user payment, we don't know really what the costs are. And I think finance needs to be brought to not only in regard to what it costs to have an intervention and is it cost effective, but really to the prescriber also. And in many developing countries, that's not the case yet. We hope to be able to prove an effect of increasing financial management in the study we do. We cannot have evidence for it, but I think from some of the other studies, the importance of knowing what the services or the medicines cost is critical for influencing behavior and rational drug use.
Thank you very much, Birna. Yes, please. The lady.
Okay, I am Yumna Tariq from Egypt. I want to ask about something less different from your track. We are in Eastern Mediterranean region have a very bad problem that we in prescription doctors write in trade names, okay? We seek that we are pharmacists, seek to write a prescription in scientific name that's of the active ingredient of drug. So now with trade name, we have a big problem that according to doctor and its promotion, it maybe poor people that should pay that prescribed drug that may be expensive. So, and the patient may be worried about, no, I have that, what doctor write, no, instead of that. So they, according to promotion, that make doctor write expensive drug to poor people, and we are in pharmacy, patient himself not want to take instead. That's our worry. Okay, that's just a different take, but it's important note that I should say. And there is now in Egypt beginning of to seek that and just apply. But I don't know if that will true or not. I don't know. Thanks.
Right, thank you very much indeed. So you are saying write prescriptions by international non-proprietary name. Is that what you are saying, correct? Yes? Yeah, and not use trade names and don't be vulnerable to promotion. Yeah?
Write them in valsartan, cephalosporin, that's okay? Not the trade name of the drug according to company.
Right. Thank you very much indeed. So we've got more recommendations. One list, national list, one list linked to reimbursement purposes, teaching to be practical with hands-on, and essential medicine concept to be included into constitution, and essential medicine list linked to treatment, to standard treatment guidelines. Have I grasped it all, what we've just discussed, dear colleagues? Yeah. Right, and periodic revisions, absolutely, thank you very much. If only we manage to do it all, will be great. Yeah, periodic revisions. So now we're coming to research gaps, yes? And Yegin is going to comment on that. Please, Yegin, thank you.
Sorry, before I comment on research gaps, can I just add something about the training share a little bit of experience of NPS's training experience. Apart from the hands-on or the other experience, I like to emphasize have established a long-term commitment training workforce is as important. At NPS, we have this about 150, we call the NPS facilitators. They are contracted by NPS. Some of them already with us 12, 13 years. So most of them are qualified pharmacists, and they not only just have a technical knowledge, but for the long-term commitment, they establish the good relationship with primary care providers. So they have a good reputations among general practitioners. So these are important for success for training program. I just want to add that. For the research recommendations, I thought about two to start with. We are a little bit struggle with linking the programs of rational use medicine, we call the quality use medicine, to health outcomes. So the end of the day, we are interested in the improved health outcomes. So if anybody have any experience in this area, I'd like to hear, or for future research area, we'd like to explore with you. The second research recommendation from me is, can I just change my hat a little bit from Australian to China? When I saw the essential medicine list of Chinese government, I had mixed feelings to see traditional Chinese medicines on the part of the list. Pleased to see part of the list is Chinese herbal medicine. As a public health physician, I was have a little bit of concerns of the evidence of these medicines. So a couple of questions already to Dr. Sun about the Chinese herbal medicine and essential medicine list. So whether we can have a more research agenda in terms of a Chinese herbal medicine or traditional medicine of a proper epidemiological study published as evidence for that. Thank you very much.
Thank you very much, Yegin. Any other suggestions? Yes, Ambrose?
Yeah, well, I think just to go on that, I think the case of China is very, very interesting, because when the indicators were introduced in the 90s, early 90s, you find that there was no data from China at all. And I think it took quite a long time for us to start having data from China. So I think that is an area, there are lots of questions about use and, using the indicator to expose the drug use pattern in China. And also with the various systems which you have in China, it would be nice to find out what influences, they might have on each other. So I think that is very, very interesting. Again, the other bit which I think the issue of sustainability, which came up now and again, we really don't know factors enough. It appears that it came up of factors that might affect the sustainability of some of these programs. I think that's an area which we ought to look into. Well, how can some of these intervention programs be sustained? I think we should look into that. And just, the other bit again is relating to the impact of the essential medicine list on rational drug use. I don't think we've got a picture from Thailand, but I think we should look into this area, more in-depthly to find out what's going on. And the influence also of institutionalizing intervention programs. I see that from the various presentations, you find that the multi-pronged or multifaceted approach seems to be working, and I think that was part of the thinking. But we have to look at the institutionalizing the intervention programs, what effect it is having, other than ad hoc intervention programs. I think these are some of the things which, we should be thinking about, which I think are research questions which we should try to fill. Yes, and Lovo, you want to say something?
I'm Lovo from Zimbabwe. I am a physician, so I just thought I should add to this issue of saying who should be the trainer. Because in my committee, it's mainly physicians, as in not clinical pharmacologists, not pharmacists, and I think I have a preference for using the physicians to train in rational use of medicines. So, but I think we need the evidence. Should it be a pharmacist? Should it be a physician, or what do you call it? A clinician to train in rational use of medicines?
Well, I think that is quite good. I think, though you might be, well, we might go back to that again. We appear to have omitted the curricular provision for training. I think that is an area which we must not forget. I think one of the recommendations, there should be some curricular provisions. You were raising your hand here, please.
Microphone, could you please help with the microphone?
Hi, I have a research suggestion, but I want to come back to you. I think it should be peers. So I think you just have to say that whoever in your country is doing the prescribing and the dispensing, they have to be trained in the rational use, and then they have to train their colleagues, because there are places where it's a nurse, it's a medical officer, whatever. For our research agenda, I want to go back to our colleague from Egypt, and also this idea of the essential medicine list, but can we do research on how to get information about what medicines are on the essential medicine list out to the community, as well as why it's generics, right? Can we get good examples from countries that have done that publicity campaign so that we know how to target news about essential medicines lists so you get uptake and agreement? I'm sorry?
Can you repeat that? What is the research question there?
What is the uptake of the
Yes.
essential medicine list? Is that correct?
Yeah.
Yeah. By the community. Yeah.
By the community, including agreement to use generics.
Let them get it there, we'll get back to you.
Sorry, both the lady from Egypt and the other lady prompted me on a question. We're now seeing some of the European countries introduce compulsory IN prescribing. So they've done it in Lithuania recently, they've done it in Abu Dhabi. Countries such as the UK have very high voluntary INN prescribing. I think about 85% of all scripts and about 99% when a drug goes generic. So my research question is, what of those countries who've introduced compulsory or voluntary INN prescribing, what have they done? What are their processes? And how then can we utilize that for countries like Egypt and the others, where the patients could be very confused, particularly if we have the concept of branded generics? I think that's been said quite a lot. That if a patient, if you go to one physician, you get one branded generic, you go to another, you get another, and you could end up with 5 branded generics, all with different names, and you could have, and that leads to all sorts of adverse reactions and things like that. Whereas INN name cuts across that, it also means there's a seamless transition from the brand to the generic, so the patients don't know the difference. So they then feel comfort in the generic because they just had the generic name from the outset. So my research question is, can we do more around INN prescribing? And the other one, which is linked to that, which Richard and I have been talking about, is what about the interface? A lot of these high-cost medicines or brand medicines originated in hospital, and then the GP is reluctant to change them to a lower-cost one. So can we do research around that interface so that we don't run out of money? So firstly, can we have compulsory INN prescribing, and how do we do that? And secondly, obviously apart from some limited situations, and B, can we research more around this interface, again, to help to save money?
Thank you very much, Brian. Thank you very much. I hope we are writing it all down and managing. And there is one more question again from Alexandria, and we're greeting our colleagues contributing to us there. Thank you very much. So the question comes from Hospital of Alexandria Hospital, Department of Ophthalmology. Why we don't evaluate the impact of formulary, as it will certainly be the most effective drugs, policies, standard treatment guidelines, but the main problem facing the formulary is the cost of updating it. I think I managed, yes. So this is the question, and if there are any suggestions to it, we are taking it as a research question, yes? So, Ambrose, we would like to wrap up.
Well, let me wrap up. But I've been advised that we are out of time. And definitely, I think this is something that should be looked into, the impact of formularies, essential medicine list, and the even standard treatment guidelines. I think the impact on this, definitely on the cost-effective use of medicines is quite appropriate and should be, will be a very good research question. Now, I think, let me quickly refer you to abstract 203, 374, 359, on essential medicines list and other aspects of our topic of discussion. And so at this point, I want to say thank you, and it was nice also sharing our session with our colleagues back in Alexandria University, Egypt. So if you are hearing us, we tell you hello, and thank you for being, and thank you for being with us, during this session. So thanks for keeping with us during this session. I think we'll see how far we go with the policy recommendations which we have come up with in this session. I will quickly present this to the speakers. I've been advised to do so. I think it's a pleasure to give this to Birna.
Thank you very much.
Thank you, Birna. Thank you very much. Then I'll give this to Sanita. Thank you for the presentation on behalf of the organizers. And this to Yegin. Thank you. And then this to Son from China. And I'll now give this to Lilia, my co-moderator. Thank you. Yeah. So thank you. I think that brings us to the end of this session.
Dear colleagues, thank you very much indeed.
Yeah.